So thank you very much, Bhagav, and I would like to congratulate you and your team for having come out with this concept of holding these webinars on different various topics. I'd like to first congratulate you. And
Thank
I'd
you so
like to
much, sir.
thank you and Akshay for having given me this opportunity to talk on this particular topic, a very interesting topic on anterior skull-based tumors. I just would focus on anterior skull-based tumors for this webinar series. There'll be two lectures today and on 3rd of May, as you all would be aware. So today I'm going to restrict my talk on the clinical, essentially the clinical presentation and how we go about working up the patients and what are the general broad concepts of treating these patients overall. And then we can take questions, and then the subsequent talk in the next webinar we talk about the surgical anatomy and the indications, contraindication, and the steps of surgery, complications. So in this part I would be dealing with the modalities of treatment, which will also include the adjuvant therapy. So with that I would like to start this uh, talk. So skull-based tumors are very rare, and most of the skull-based tumors, 50% of them are benign, of which juvenile angiofibroma is also part of, which is not the focus of this present topic. So now this topic, in this talk, we'll be just looking at malignant skull-based tumors only. So we all know that malignant skull-based tumors comprise of 3% of all head and neck malignancies and less than 1% of all cancers overall. If you look at the common sites within the nose and paranasal sinus, maxillary sinus is the most common site, followed by nasal cavity. You can look at the percentages that are there adjacent to it in decreasing order, starting from maxillary sinus, the nasal cavity, the ethmoid sinus, and the sphenoid and the frontal sinus. So this is the order in which the site of origin of anterior skull-based tumors are. Now, anterior skull-based tumors are challenging to deal with because of its very location, and it is surrounded by very vital, important structures which needs to be protected during surgery and also during delivery of the adjuvant therapy. So it gives it poses important it poses a lot of challenge to the treating team, and it's a multidisciplinary treatment for skull-based tumors. So it involves a lot of oncologists, the surgical, the radiation, and the medical oncologist. Now, there is no standard and uniform protocols of treatment. Now, you must be aware of all the NCCN guidelines, the NICE guidelines, and so on and so forth. For various common cancers like the oral cancer, the thyroid cancers, larynx, hypopharynx, oropharynx. But you would not find one such guideline which is very clear for skull-based tumors for various reasons. One being it's very rare compared to all of these cancers that we just spoke about, and there's a lot of heterogeneity in the histology and the staging of disease. So there's a wide plethora of histopathological diagnosis, and the treatment varies with different types of histopathology. And also absence of prospective studies. That's again because of the fact that these are rare tumors and we cannot possibly do a randomized control trial to see which treatment modality is better. So the treatment philosophy is basically driven by large retrospective series, which are institutional series, case reports, and systematic reviews of all these huge series. Now, WHO has classified the nose and paranasal sinus histopathologies, and in 2017 it was revisited, and we'll just look at the various histopathology. The borderline tumors are inverted papilloma, hemangioparasitoma, and hemangioendothelioma. We'll just look at these towards the end of the talk. The malignant tumors are basically divided as malignant epithelial tumors, the one arising from the epithelium of the nasal cavity and paranasal sinuses. The mesenchymal tumors such as sarcoma, the neuroectodermal and melanocytic tumors such as the esthesioneuroblastoma, mucosal melanoma. Teratocarcinosarcoma is a different variety of skull-based tumors, and other rare malignancies, such as hematolymphoid tumors, are also part of the skull-based tumors. And meningiomas, we know, is locally aggressive uh, and is part of the skull-based tumor. Um, Mostly handled by the neurosurgeons, but at times we do handle it as well. So we'll just see all of these skull-based tumors, just to look at each and every tumor individually, and what is the broadly the treatment philosophy for each and every subtype of these tumors. So before we go that, just let's try to look at what are the various etiologies, clinical presentation, the investigation. How do you go about doing a workup for these patients? And we'll talk a few things about what you need to do when you look at the imaging, and then we'll deal with the individual histopathology types. So etiology, cigarette smoking is linked to many malignancies, but as far as the skull-based malignancy is concerned, it is implicated but not well established. And certain things like exposure to wood dust is strongly associated with the incidence of adenocarcinoma, especially in the European countries. They have strongly come out with this association being established. So this is known to be associated commonly with ethmoid sinus malignancies, and a minimum exposure of 10 years is what is required before the malignancy goes on to develop. And this wood dust exposure, which gives rise to adenocarcinoma, is multifocal, because the wood dust goes and comes in contact with the nasal mucosa and gives rise to the metaplasia that is happening, and sets in the metaplasia, and it converts into the intestinal or non-intestinal type of adenocarcinoma. And they can be multifocal. So though if in imaging, if you see the cancer only in one side of the ethmoid sinus, it may be worthwhile doing the surgery bilaterally, because the recurrences are known to occur at a totally different site due to the multifocal nature of exposure. The other etiologies are chemicals such as nickel, chromium, which we all know, and mineral oils, which is related to the petroleum industry, the radial dial painting. These are all also been implicated with the development of skull-based malignancies. The exposure to radiation is generally implicated with the development of sarcomas. It is an association that has been noticed, and not 100% or strongly correlated, but as what the wood dust has been strongly correlated with the development of adenocarcinoma, but it has been shown that is associated with sarcomas, radiation and sarcomas. Clinical features, we all know it's mostly nasal symptoms, but one thing that needs to be understood is many times the patients are asymptomatic and they may have non-specific symptoms, which is a reason why they may present late. And it's been found in various studies that the average delay till the diagnosis is up to 6 months because of this. And the most common symptoms are nasal symptoms and cranial neuropathies, because of the fact that it's in the skull-based region. Clinical examination, apart from the general examination and examination of the nose, paranasal sinus, we need to examine the cranial nerves, especially the extraocular muscle movement and the cranial nerves associated with that, the olfaction, and of course vision. So in general, the cranial nerve examination is very crucial. The other investigation is a diagnostic endoscopy to look at the lesion as to where it is originating from, if it can be seen. Sometimes it cannot be seen because it might be in non-accessible areas, but mostly it would be seen. And the other important thing is to not to forget to do an examination of the neck, because some of the tumors can present with a neck node, like for example the olfactory neuroblastoma, the squamous cell carcinoma. These histologies can present with palpable neck nodes, which needs to be addressed, and also the mucosal melanomas. These are all very aggressive tumors. They can present with neck node, but in general, in all these skull-based tumors, malignant skull-based tumors, should not forget to do the examination of the neck as well. Coming on to the investigation, the first and foremost investigation is, as we would do a diagnostic nasal endoscopy, is to do a biopsy to establish an histopathological diagnosis. And it's crucial for planning the treatment, because the treatment may slightly vary depending on the histopathology and the grade of tumor and so on and so forth, that we will just see as we look at the various treatment, various histopathological types. And slide review. If many times, I mean, we being in a tertiary cancer center, the patient would come to us, and I'm sure it would be an experience to many of you. The patient would come to you with already a biopsy report and the slides and blocks. In which case, it is a good idea to get the slides reviewed, because one of the studies done at MD Anderson showed that when you do a slide review, there is a change in diagnosis. Up to 70% of the times. So, and it also requires a very good pathologist, because there is a lot of immunohistochemistry that would be involved to come to a diagnosis. And it's, believe me, it's very challenging to come to a diagnosis of many of the skull-based tumors. And there might be time wherein you still will not be able to come to a conclusion. Your pathologist might just tell you that it's a poorly differentiated carcinoma or a malignant sarcoma, and we really cannot subtype it as whether it's an Ewing sarcoma or a chondrosarcoma or a chondroma, or is it, what is the type of tumor? Is it a neuroendocrine carcinoma? They'll just say poorly differentiated carcinoma. It could be a neuroendocrine carcinoma, it could be a lymphoma, it could be anything. But at times it will be really difficult to come to the exact diagnosis. So it's a big challenge establishing the correct diagnosis in a skull-based tumor, because that drives the entire treatment ahead. And also, of course, the prognosis that that will be given to the patient subsequently. And then imaging. This is another very important part of your workup. And in skull-based tumors, we have to do both a contrast enhanced CT scan and an MRI. Both has to be done, and they are complementary to each other. We probably cannot get away with just doing a CT scan or an MRI. For skull-based tumor, and also it's a policy in our hospital that we do both. It's a complementary investigation to each other, and it would help us to come to a diagnosis. Many times, like chordomas or chondrosarcomas, you would have to rely heavily on the imaging to differentiate what it is. And in general, the MRI, most of the skull-based tumors have a low to intermediate signal intensity. And MRI also, it's better to do a gadolinium enhanced, contrast enhanced MRI. And T1 weighted contrast MRI would give you a clinching diagnosis many a times. And also MR angiography in certain vascular tumors would be done, not always, depending on what type of tumor that you're dealing with. Then you come to the metastatic workup to stage the disease as such. And we would do a PET scan is recommended. It's not only we do that, it's also recommended for high-grade tumors and for advanced stage tumors, T3, T4, which would be the case in most of the skull-based tumors. You would hardly get you would not commonly come across a T1, T2 tumor. Most of them would be an advanced tumor, and in which case you would want to do a PET scan to stage the disease upfront. And in certain tumors, such as the adenoid cystic carcinoma, or then maybe a CT thorax is good enough, because that's the most common site of metastasis, and you wouldn't expect an adenoid cystic carcinoma to metastasize into a different metastasize widely to the entire body. So mostly, if you would do a PET scan, but a CT thorax may also be good enough in some of the type of skull-based tumors. So again, that would be driven by the histopathology that you also get. So initially, if you have not done a PET scan, and if you get a diagnosis of a high-grade tumor from your biopsy, you might definitely want to do a PET scan before you proceed. Now, in imaging, what should your imaging be able to tell you? The most important, the local imaging, that is the CCT, the paranasal sinus, or the MRI, will tell you whether is the lesion resectable. So you would look for whether there's extension of the tumor involving the lateral and superior sphenoid wall, wherein you have structures such as the optic chiasma, the optic nerve, the carotid artery, and the cavernous sinus that's situated. So if there is involvement, erosion of these two areas. Now, remember, we are talking about malignancies, and we're not talking about benign lesions. We're not talking about chordomas. So here we are talking about malignant lesions. So in which case, lateral superior, these are all contraindications. These will make the lesions unresectable. Let's say you have a squamous cell carcinoma or a olfactory neuroblastoma with a lateral sphenoid or a superior sphenoid wall involvement, cavernous sinus involvement, optic chiasma involvement, or bilateral optic nerve involvement, extension into the nasopharyngeal area, or infiltration into the prevertebral fascia. So these are the things that you need to look at, and these would make the lesion essentially unresectable. And also the structures that need to be sacrificed to achieve a total resection. So you need to know where all the disease is extending, it superiorly, whether it's going intracranially, whether the dura is involved, laterally, whether it's going into the orbit, and these are the things that you need. So if there is extension into the orbit, we'll just see in the subsequent slides. So you would have to make a plan as to what all you need to resect. And sometimes the tumor might be deeply seated, and just a simple nasal endoscopy and biopsy might not be feasible. So in which case, a CT scan will all help you decide what's the route of biopsy, whether it has to be a surgical procedure, or it can be a imaging guided biopsy as well. Many a times we resort to that because it's so deeply located that you might not be able to the biopsy itself might be a big surgery. So in which case, imaging guided biopsy might help. And also, if it is all resectable, then which is the best surgical option? That is, so your imaging should be able to give you an idea basically about all of these things. So imaging, so of the anterior skull base tumors, basically you'd look at three essential things. One is the anterior cranial fossa invasion. So you'd look for, if you look at the image here, you'd look for whether there's any dehiscence of the anterior skull base here. You see the cribriform plate here, and the lesion is going and involving the cribriform and the crista galli. So you essentially look at whether the lesion is eroding into the cribriform plate, which can be seen in a CT, and then in MRI you'll see there's a loss of hypointense signal in the MRI. There'll be a black line there between the parenchyma and the sinus, which is lost. That means the bone will be seen as black line. So that would be lost. The next thing that you would look for is any dural thickening. If it is more than 5 mm, would be considered as significant dural thickening, which may amount to involvement by disease. And the next thing is nodular enhancement. So these are all findings that should alert you that this will tell you that probably a dural resection is required. And also you have to look for how much of this dural thickening is going laterally and posteriorly. That will also tell you as to what kind of approach, whether you're doing an endoscopic approach, or you have to do a combined approach, or you have to do an open approach. So all these things will be points to be noted. Like for example, here in this point, in this picture here, if you see the lateral extension going almost closer to the midline on either side. So for a margin, if you take the resection of the dura on either side, this dural defect will not be able to be reconstructed endoscopically. You will not achieve a seal. So the chances of a CSF leak post-operatively would be higher. So in this case, you would want a pericranial flap to be put in to achieve that seal. And similarly, when you look at posteriorly, if you see the tumor, this is the cribriform area, and this is the planum. So if the lesion extends posteriorly towards the planum, then again here the dural attachment to the planum is pretty. The dura at the planum is thin, and it is tightly attached uh, uh, to the bone, underlying bone. So if you resect the dura posteriorly, even if you put a pericranial flap, it becomes difficult to suture the pericranial flap to the remaining dura, and becomes difficult to achieve a seal. So all these points you need to look for when you're assessing the resectability of the tumor, whether you want to go up front, whether it's resectable or not, whether you want to do upfront resection, or what is the plan. Other thing is the leptomeningeal and parenchymal involvement, and the brain edema due to the disease per se. So these are all the factors that you would want to look at as far as the tumor in the anterior cranial fossa is concerned. Now the next thing is the orbital invasion. You'd look for whether there's involvement, if the tumor is in the going closer to the orbital apex, whether the orbital apex is involved or not, and if it is involving the orbit, as to whether what is the grade of involvement. So the grade 1 here is just erosion of the medial orbital wall, just the lamina papyracea. Grade 2 is extracorneal invasion of the periorbital fat. And grade 3 is invasion of the medial rectus muscle. You can see that as this red arrow points out, that's the medial rectus. It's abutting the rectus, and it sometimes it may go beyond that. So this is a squamous cell carcinoma, and you see the muscle abutting the rectus. So it is mostly in this grade 3 involvement that mostly you might have to decide that to do an orbital exenteration. But having said that, even for grade 2 and grade 3, you might have to take a consent for an orbital exenteration. But for grade 3, definitely an orbital exenteration is would be required. But for grade 2, if the periorbiter can be sent for frozen section, and the fat, if it is free, and the muscle is not involved, then you can spare the orbit. So these are all the things that you need to look for in the imaging. The other thing is, many times if you just do a plain CT scan, you will not be able to differentiate between the tumor and secretion. Like for example, in this, you see the tumor here, and the sphenoid sinus is here, and these are the two bilateral internal carotid artery in the sphenoid sinus. And here you see the secretion, and this is the tumor. So MRI, T1 weighted contrast MRI will definitely, this is one T1 weighted, and will definitely, sorry, this is a T2 image. This is not T1, this is a T2. Sorry, you can see the vitreous glowing up. So all the fluid, the CSF glowing up, it's a T2. This is best seen, the differentiation between the tumor and the surrounding is best seen with a T1 weighted contrast. But in a T2 also, this can be made out as seen in this. And also for involvement of the neurovascular structures. In this case, here the carotid is just abutting the carotid, but it's not encasing it. Sometimes you'll see both the carotid arteries encased in a case of a chordoma or sometimes a chondrosarcoma. Now, that is about what are the, broadly speaking, what would be the various things that you need to look for in an imaging. And this imaging session itself could be a webinar for a couple of webinars actually. But then you need a very good radiologist with you in your skull-based clinic to actually come to to have a good dialogue as to decide on the extent of tumor, the resectability, the relation to structures involved, so on and so forth. Just based on a pure radiological imaging, you probably cannot plan treatment. You always need a histopathological diagnosis to go ahead with treatment for malignant skull-based tumors. And also you would require a radiologist in case you are not able to do an endoscopic biopsy to plan an image-guided biopsy. So once you have all of this diagnosis and the imaging in your hand, now you need to plan for the treatment. Now let's start with squamous cell carcinoma. So I'm just going to outline the basic philosophy of based on the existing evidences that you have. For most of the tumors, you probably would not, you don't have any randomized control trial for sure. So all these are retrospective case series. There are very few prospective studies that are there, if at all, that are there. So for squamous cell carcinoma, which is the most common histopathology type, up to 80% of the time at times, treatment for most of the skull-based tumors, surgery remains a very important part of your treatment. But then it's a multimodality treatment as well, and the sequencing of this treatment, whether surgery comes first or chemotherapy comes first or later, radiotherapy comes later or first. So these are the various things that needs to be decided, which we know from literature, from all these various systematic reviews and reports and the studies that have been published. So surgery followed by adjuvant radiotherapy is the best treatment option for squamous cell carcinoma. When you know it is upfront resectable, we have seen when do we decide about the resectability. If you feel it is upfront resectable for squamous cell carcinoma, it is surgery followed by adjuvant radiotherapy. Now, adjuvant radiotherapy, remember, it is in the skull base area. It is especially in the skull, in head and neck per se, but more so for skull base area. The IMRT is the usually recommended modality for delivery of adjuvant radiotherapy. That's because you can plan your radiation delivery appropriately, and you can spare the essential structures such as the optic nerve, the parenchyma, the optic chiasma, so that the side effects can be minimal, the temporal lobe and things like that, and the various structures. So remember, any radiotherapy for the skull base, either definitive or adjuvant, IMRT is a recommended modality of delivery. And for all these skull based tumors, elective neck dissection upfront is not recommended until and unless the patient presents with a palpable node, or in the imaging you find a metastatic node which is proven with your FNAC or image guided FNAC. So that's because of the fact that even in squamous cell carcinoma, the incidence of neck nodal metastasis is less than 20%. So we all know that elective neck dissection is recommended when you have the, even in T3, T4 cancers is less than 20%. So the elective neck dissection in N0 neck is recommended if the incidence of neck nodal metastasis is upwards of 20%. So for all these skull-based tumors, until and unless you have a palpable node, or if you have a suspicious node on imaging or an FNA proven node, neck could not be addressed surgically. But then the neck might be addressed with your adjuvant therapy, like elective neck irradiation can be considered after surgery for the primary. In this case, the dosage would be very minimal, and the toxicities due to radiotherapy will be less. So it still can be considered. The dose would be close to 50 to 54 grays. So then it can be handled by the patient pretty much. And the other option is, like, for example, when there is a minimal intracranial extension, when it's going posterior to the planum, and so in which case, sometimes a neoadjuvant chemotherapy with taxanes, that is docetaxel and cisplatin, can be considered, followed by local therapy if there is a good response. Because here you give NACT with that concept that to downsize the disease, so that we can resect with more confidence, and you'll be able to reconstruct the defect and minimize the CSF leak. And also, one of the concepts of NACT is to you bioselect your patients. So if a patient responds to your NACT, they would be the tumor. It's a good tumor. And certain institutes use this philosophy also to give further treatment in the form of non-surgical treatment. So there is the concept of patient responding to chemotherapy will also respond to radiotherapy. So they give chemoradiotherapy. We'll just be talking about that in some of the other tumors. But NACT, in squamous cell carcinoma, that is not the case. Squamous cell carcinoma, NACT followed by surgery, and then adjuvant therapy. If it is considered unresectable, then we would consider non-surgical treatment options in the form of chemoradiotherapy. But this is in general about the philosophy of treating squamous cell carcinoma. The next common carcinoma is the adenocarcinoma. Now, here, the non-salivary adenocarcinoma. The salivary adenocarcinoma mostly is seen in the maxillary sinus and in the palate, the hard palate. Here, this we are talking about in the nasal cavity and the ethmoids. So these non-salivary adenocarcinoma are essentially divided into intestinal and non-intestinal type. The non-intestinal type is again divided into high grade and low grade, and this is a lesser common variety of the non-salivary adenocarcinoma. The more common variety is the intestinal type. So the intestinal type again is further subdivided into papillary, colonic, solid, mucinous, and myxoid. This is depending on the architecture. And as you can see, the red arrow, the prognosis is worse as you go down this list. So essentially for adenocarcinoma, again, surgery followed by adjuvant therapy is the treatment of choice. But if the lesion is again, like what we discussed, if it is borderline resectable situation, then in that case NACT could be considered. And there was a study done by Licitra and colleagues, and there was a retrospective and there was a publication on the series of close to 100 patients by Bossi on adenocarcinomas. What this is an interesting concept wherein they used NACT in patients with adenocarcinoma, and this was based on the functional P50, the type of P53, and whether it was functional or not. Patients with a wild type P53 and functional wild type TP53 and functional P53 were better responders. And when you gave NACT to that, to these patients, survival was better. So there is a concept wherein certain institutes follow that when they do a biopsy and it comes out to be an intestinal type, they look for P53 mutation status and whether it's functional or not. If it is wild type and functional, in that case, they would consider NACT and then go for surgery, in which case the survival is better. But and the NACT is given with cisplatin and 5-fluorouracil. This is one school of thought, and this has been tried and shown to have good impact on survival, positive impact on survival. Having said that, if the lesion is resectable upfront, surgery followed by adjuvant therapy is the treatment of choice. NACT again could be considered in cases of borderline resectable lesions. Adenoid cystic carcinoma, there's very little doubt in this. Surgery followed by adjuvant therapy is the treatment of choice. Achieving negative margin is crucial for any malignant skull-based tumor, and it's no different in adenoid cystic carcinoma. And there's no role of chemotherapy in adenoid cystic carcinoma. It's just surgery followed by adjuvant therapy. And even when there is a recurrent lesion, it is again surgery followed by adjuvant therapy if there is a considerable gap between the previous irradiation and the recurrence. The other histopathological type is the sinonasal undifferentiated carcinoma, also known as the SNUC. These are high-grade tumors, and they have a tendency to have present with distant metastasis of up to 20 to 30%. Now, we have not seen that in the previous histopathology so far, but this is one type of cancer. When you have this diagnosis, you would first do a distant metastasis workup upfront. And the treatment strategies vary between institutions. There is no common consensus on this, but one thing is for sure, it's a combined modality treatment. And there's no single approach or single treatment philosophy that has been shown to be better, but better in comparison to one over the other. Many institutes have tried different philosophies. Now, the MD Anderson Cancer Center series, which was published recently, shows interest in that they have seen that NACT and patients who had a good response, that is partial responders and complete responders, they went ahead with chemoradiotherapy in majority of the patients, and there were a few patients who received surgery as well. But then NACT responders to NACT, that is partial response and above, when they give chemoradiotherapy, they had a survival advantage and they did better. So that is one philosophy. So at our institute for SNUC, we would give NACT, and we would, if for responders, we would operate and then give adjuvant therapy. So then the philosophy varies with institute, but then NACT would probably be the first thing that you would want to give in a sinonasal undifferentiated carcinoma, because for two reasons. Most of the time they present with an advanced stage disease, and you have a chances of 20 to 30% of distant metastasis. So NACT, again, one of the concepts of philosophies of giving NACT is also to reduce the chances of micrometastasis. So this could again be a point that NACT is preferred rather than doing upfront surgery for a SNUC compared to the previous two, adenocarcinoma, adenoid cystic, and squamous cell carcinoma. Now, sinonasal neuroendocrine carcinoma, again, is a rarer kind of tumor, and the well and moderately differentiated varieties, that is the carcinoid and the atypical carcinoids, are very less often seen in the skull base. The one that is commonly seen is the poorly differentiated one, which is again divided into a small and large cell type. The small cell type is the more aggressive variety, and they tend to present with distant metastasis. And again, this is a multimodality treatment, and surgery remains a cornerstone. And the treatment philosophy for sinonasal neuroendocrine carcinoma is more or less similar to SNUC. You would probably want to give neoadjuvant chemotherapy because of the chances of these patients presenting with higher incidence of distant metastasis, and then go ahead with surgery and followed by adjuvant therapy. So this philosophy might vary, but this is what more or less many people follow. The other new entity that has come up in the list of the WHO classification in the 2017 revision is the nut carcinoma. this is the nuclear protein of testis. That is the abbreviation for this, and it's a high-grade tumor. It presents with a round blue cell morphology. You know the differential diagnosis for round blue cell morphology is the rhabdomyosarcoma, mucosal melanoma, Ewing sarcoma, the lymphoma. All these are a differential diagnosis, and now you have this nut carcinoma as well. They also arise from the epithelium of the paranasal sinus, the nasal cavity, and it's a very aggressive tumor, high grade tumor. Again, in a case in point where you will do a PET scan once you have this diagnosis. Believe me, it's a very difficult diagnosis to have, but then once you have it, you would want to do a rule out distant metastasis before you go ahead. It's a multimodality treatment. Surgery remains the mainstay. Surgery followed by adjuvant therapy. It's highly aggressive. Whatever the treatment that you offer, surgery, neoadjuvant, adjuvant, whatever it might be, the median survival is less than 1 year. There were only few cases reported so far, less than 100 in number, but the survival has been less than 1 year in all reported cases. It's very, very aggressive tumor. So you have to go all out if you have this diagnosis, rule out distant metastasis, and then only proceed ahead with surgery. Teratocarcinosarcoma is another variety, which is a very rare entity, but you do see them once in a while. It arises from the skull base region, and it is locally aggressive. It mostly has intracranial extension, and it may present with neck nodal metastasis as well. So you have to evaluate for the neck, and you have to locally it's aggressive, and you have to rule out distant metastasis, and then surgery is the treatment of choice, followed by adjuvant therapy. That is, as already mentioned, elective neck dissection is not recommended if it is a patient presents with a metastatic node, or radiologically it is doubtful, it has a metastatic node, then you address the neck. Similarly, you don't do an elective neck irradiation in a teratocarcinosarcoma. It again varies with institution philosophy. As I've already said, it's a rare tumor, so you cannot have a sacrosanct statement on this. So, but more or less, people don't electively irradiate the neck for teratocarcinosarcoma. Olfactory neuroblastoma is again a very, it's a commoner type of tumor, though considered rare, it is commoner. You have various series, systematic reviews of 1,000 plus cases. So it's not all that rare compared to the previous 3 histopathological diagnoses that we have seen so far. And they originate from the olfactory neuroepithelium in the nasal vault, and it's a multimodality treatment for this entity. It's not, and surgery is mostly craniofacial resection. It is not, it can be endoscopic, it can be open depending upon the extent of disease, and surgery followed by adjuvant therapy. Now, the role of chemotherapy has been less explored, but of late you are finding reports wherein people have given, especially the MD Anderson Cancer Center have published, wherein a neoadjuvant chemotherapy has been given for advanced disease and high-grade tumors. We'll just come to that in the next slide. And then followed by surgery, and then adjuvant therapy gives a favorable prognosis. Now here, the olfactory neuroblastoma, you have the Kaddish staging. A is tumor confined to the nasal cavity, B is extending to the paranasal sinus, C is including the involvement of the cribriform plate, the skull base, intracranial extension and orbit. D is when they present with distant metastasis. D is a later inclusion into the Kaddish. Initially it was A, B, and C. Now it is D as well. Now the Himes grading system is very important for olfactory neuroblastoma, but because that helps us to prognosticate the patient and also plan the treatment. Now I already said that there are reports coming in where the role of neoadjuvant chemotherapy is slowly evolving, and and patients with grade 3 and 4 Himes grade variety of olfactory neuroblastoma tend to respond to chemotherapy as well, and their survival also seems to be that much more better once they receive NACT and then local therapy. Mostly the local therapy is surgery followed by adjuvant treatment, which could be radiotherapy with or without chemotherapy. So that is the treatment philosophy that is evolving, and even at our institute, for advanced lesion, when there's intracranial extension and also when there is Himes grade 3 and 4, we tend to give a neoadjuvant chemotherapy and then plan surgery. Now, Himes grade 4 and nasal neuroendocrine carcinoma and SNUC. These three cannot. It's very hard to differentiate the three of them. It's really hard. You need to have a super pathologist to actually tell you the difference between the three. But more or less, the treatment philosophy for these three is the concept of neoadjuvant, evaluate response, and then give local therapy, which is mostly surgery, and then adjuvant therapy. Now, the next other histopathology type is a mucosal melanoma. It's again a rarer type compared to olfactory neuroblastoma, but again, it's a very high-grade tumor, has a poor prognosis, but not as bad as the nut carcinoma. Nut carcinoma is the worst among the lot, but it does have a poor prognosis. Lower incidence of neck node metastasis. Again, you would not electively address the neck in any of the skull-based tumors until and unless, as already mentioned, if they have a positive neck node or radiologically metastatic node. Surgery remains the mainstay because radiotherapy, these tumors are radio resistant, but you would give adjuvant radiotherapy. And now there is evidence to also back adjuvant chemotherapy. Cisplatin with temozolomide is being considered as an adjuvant chemotherapy option. That's being tested in a randomized setting and has shown to provide benefit. Distant metastasis is the most common mode of recurrence. That again makes sense as to why you would probably give an adjuvant chemotherapy, like in nasopharyngeal carcinoma. Initially, it was given in nasopharyngeal carcinoma, but then now it's shown not to offer any benefit. But then in this case, there are evidences that are emerging that shows adjuvant chemotherapy has a benefit. The next is sarcomas of the skull base. Now, sarcomas of the skull base, there are a lot of them. You have Ewing sarcoma and osteosarcoma, synovial sarcoma, rhabdomyosarcoma. Now, many of these sarcomas are non-surgical entities, meaning to say you would not upfront go in for surgery. Ewing sarcoma is one of them. It's rare, mostly seen in younger patients. Many of them would be pediatric age group. Treatment is multi-modality. Usually you would give NACT, which includes 3 to 4 drugs like vincristine, adriamycin, doxorubicin, and ifosfamide. Chemotherapy. Then you would stage the patient for local therapy, surgery if it is resectable, and followed by adjuvant therapy. But many times, Ewing sarcoma would be in sites, not exactly in the anterior skull base. It would be in the parameningeal area, wherein resection may not be always possible. You would hardly come across Ewing sarcoma that could actually be resected after you give an NSTT, at least not in my experience. Maybe the patient present to you with such a advanced lesion that you would probably give non-surgical treatment option after even an NACT. But if you can resect, you should go attempt to resect. And osteosarcoma, again, most commonly osteosarcoma in the head and neck would be seen in mandible, followed by the maxilla, and then rarely in the skull base alone. And of course, you would rarely see in the parameningeal area as well. So, but then in osteosarcoma, if multimodality, there is literature saying neoadjuvant chemotherapy followed by surgery. But neoadjuvant chemotherapy for osteosarcoma is a proven concept for long bone osteosarcoma, that is extremity osteosarcoma. For head and neck osteosarcoma, there is no clear-cut benefit of giving neoadjuvant chemotherapy. So it would be upfront surgery whenever you can resect, and then adjuvant therapy if possible. Subsequently adjuvant therapy. I'd just like to touch upon inverted papilloma. Everybody will be knowing about inverted papilloma, but then just a word about inverted papilloma, saying that the association of squamous cell carcinoma and inverted papilloma in the latest literature by Lawson, published in Laryngoscope, is up to 11%. You can have it, especially in extensive, long-standing inverted papilloma, and also when there is a recurrent inverted papilloma, you should anticipate associated squamous cell carcinoma, and in which case you need to have a good clearance, negative margins, and better outcome in comparison to primary squamous cell carcinoma following treatment. And surgery, of course, remains the mainstay, and adjuvant therapy if indicated. If you've got a good clearance, maybe you can keep on hold the adjuvant therapy. But if there are other negative features like poorly differentiated carcinoma or perineural invasion and various other features, you could consider adjuvant therapy, and also depending on the stage. Hemangiopericytoma are locally aggressive tumors, and they have a tendency to recur after treatment up to 21%. And surgical excision, that is endoscopic excision or open, depending upon the location of the tumor, would be the treatment of choice. Adjuvant radiotherapy is controversial, but can be considered if if it is anticipated that the excision was not satisfactory, or you couldn't get R0 clearance, or any of these sorts. The other things in the list that we have not gone into detail is the rhabdomyosarcoma, which is essentially a non-surgical entity. You would probably do a biopsy, type, get the type of rhabdomyosarcoma, embryonal, alveolar, pleomorphic, whatever it is, and then you would give the IRS protocol, and then evaluate after neoadjuvant chemotherapy. Mostly it would be a non-surgical, because most of the skull-based tumors are parameningeal rhabdomyosarcoma. So it would be a non-surgical treatment option. Chondrosarcomas is like upfront surgery if resectable. So is the case with synovial sarcoma. The hematolymphoid tumors are mostly non-surgical entity. Once you have a diagnosis, they go for chemotherapy and in-field radiotherapy, but not surgery. Now, to just conclude, I would just like to say that sinonasal skull-based malignancies are rare. They present with diverse histopathology. Getting the right diagnosis is crucial to plan the treatment. As you've seen across the various histopathologies, that your plan might change because the existing literature gives that one treatment strategy offers some sort of an advantage over the other. Imaging is very important for the right staging and to assess resectability, and sometimes to also the route of the approach for surgical approach, and also when you're not able to get the biopsy, image guided biopsy also can be planned. Now, skull-based tumors are multimodality tumors which has to be treated with multimodality approach, and surgery remains a cornerstone. Chemotherapy and radiotherapy has an essential role to play, and depending on what evidence we have, we can choose the sequence accordingly. So with that, I'd like to conclude, and I can take some questions if you have.
Sir, there is an excellent presentation, sir.
Yeah.
And now there are a couple of questions, sir, which I'm getting in the chat. So first
Sure.
question is by Dr. Siddhant. Should we do a imaging first, as it will serve as imaging guided biopsy before doing a biopsy in these skull-based tumors?
See, that is a good question. It depends. Sometimes the patient may come to you without any imaging, and when you're able to do a nasal endoscopy office procedure and see any tumor, then you could get a biopsy. So, and many a times the patient will come to you with an imaging. So it depends on how the patient presents to you with, and then you can plan your subsequent steps.
Okay.
But the most essential thing is clinical examination. That will help you tell what needs to be done next.
Next question is by Dr. Simple B. Is craniofacial resection limited to only grade 3 or every case of olfactory neuroblastoma?
That's a good question again. Again, there's this paper from MD Anderson, wherein for grade 1 and 2, when there is no intracranial extension, that is Kaddish A and B, when there is no intracranial extension, of course, C, you'll have to do a craniofacial resection. When there is no intracranial extension that can be established, the basic principle for olfactory neuroblastoma is you have to do a dural resection, and the ipsilateral, at least, olfactory bulb needs to be removed. But they've shown that in Kaddish A, there is no difference in survival when you do it and in comparison to when you don't, and some cases of Kaddish B. So it depends on case to case basis, but definitely for Kaddish A, you can avoid doing a craniofacial resection. If you can just do an endoscopic endonasal resection, should be sufficient, and when you get a negative margin, should be good.
Okay, sir. Next question is by Dr. Ira. How much margin to be taken in case of inverted papilloma? And another interesting question on the same margins issue is by Dr. Vivek. What would be the ideal margins for skull-based tumors managed endoscopically?
I would cover on the margins in detail in the next presentation. But just to give you an idea, the basic principle in skull-based tumor is to go one cell ahead of the area where the tumor is present. And so if you have the tumor going up to the posterior ethmoid, you have to go to the sphenoid and clear the mucosa in the sphenoid sinus. And if it is in the abutting the lamina papracia, you would remove the lamina papracia and maybe the periorbita and send it for frozen. If it is negative, you would stop there. So the general principle is you go one cell beyond the tumor where it's extending to.
Okay.
Yeah.
Next question is by Dr. Ankita. She was asking about the importance of retropharyngeal node and how does it influence in surgical management?
excellent question. So that you would know as you're imaging. Of course, in one of the things I've probably didn't mention in the imaging is that you also look for the nodes in the neck as well, and the primary echelon of nodal spread for skull-based tumors to the retropharyngeal node. So if the retropharyngeal node is present, that would be some sort of a relative contraindication. But then you would you would rarely find upfront retropharyngeal node present in many of the skull-based tumors. Maybe you would find this more in case of a sinonasal neuroendocrine carcinoma, mucosal melanoma, and these high-grade histopathologies, in which case you probably would decide against surgery, because getting clearance with a endoscopic clearance of retropharyngeal node might be that much more challenging. That is one. The second thing is, it gives you a hint that this is a poor bad tumor, so to say. So even if you end up resecting this, it's doubtful whether the patient will do well after subsequently. So it will also help you to choose the patient for your treatment. Though it's not distant metastasis, these are bad tumors to begin with.
So next question is by Dr. Rahul Agarwal.
Yeah.
So what do you consider tumor-free margin for skull-based treatment, or do you do frozen for all the cases?
Skull-based tumor is one where you would definitely not do without a frozen. At least I would not do without a frozen, because you need to have that frozen control when you're doing the tumor. At least I would feel comfortable doing a frozen section. Now, if you ask for any, literature evidence, you would not find much on this, because most of them, I think, would do a frozen section based surgery.
Okay. So next question by Dr. Chaudhary. What is the role of dural involvement in planning surgical excision of parameningeal tumors?
Parameningeal tumors, I'm talking about anterior skull-based tumors. So parameningeal tumors mostly would be rhabdomyosarcoma, Ewing sarcoma, and so on and so forth. So you're not going to have, and most of the other parameningeal tumors would be benign. Let's say a schwannoma or something like that, in which you're not worried about the margins. So here, if you have a tumor in the parameningeal area, first you have to see whether it's resectable or not. If it is, and then you plan surgery there. So there, resecting the meninges in the parameningeal area and getting a seal to prevent a CSF leak is very, very difficult if you resect the meninges there. So mostly it will be an open approach there.
Okay, sir. So one more interesting question from Dr. Amir. How do you manage a hemangioma of the soft palate from the nasal side endoscopically? I mean, he's asking endoscopy. Soft palate.
Soft palate on the nasopharyngeal part.
From nasal side. I mean, he's asking how do you do it from endoscopy?
So that's what. So what I understand is hemangioma on the nasopharyngeal part of the soft palate, right?
Yes, sir.
So that can be addressed as how you would address any septal hemangioma. That of course you could have bleeding, but depends on the size of the tumor, the extent of attachment on the soft palate. So Coblator will be a good tool to use in such a case. In most of the vascular tumors, Coblator would be a good instrument to use.
Just from doubt from my side, sir, what is your opinion on pre-embolization of those vascular tumors before?
Depends. That's what. So if depends on the size and what the feeders are. If it's a highly vascular tumor, if it has a broad base attachment, you would definitely take that call as to whether you want to do a MR. As I previously mentioned, for vascular tumors, MR angiography would be an investigation that you would consider. And based on that, you would decide if it has a plenty of vascular supply, you would probably want to do embolization before surgery. But I'm sure many of them would do without that also.
Okay, sir. One of the requests is can you brief the modality of treatment for giant cell tumor of skull base?
Giant cell tumor of the skull base mostly is surgery. It's a locally aggressive tumor, and giant cell tumor, it's again difficult to have a diagnosis to begin with. You will have a biopsy which says you have some giant cells that are there. It could be giant cells could be there in any reparative lesions. Whether it's a radiological diagnosis, it's a clinical, radiological, and histopathological diagnosis. And mostly if it is resectable, it has to be surgery.
So Dr. Rakshit sir is congratulating on your presentation, and
thank you.
He is also asking you, in which situation would you do endoscopic versus an open surgery? And what are the factors that made you decide which approach you would choose?
I would do that. I would decide as to if it is a craniofacial resection, I need to know whether I can reconstruct the defect to prevent a CSF leak. after the resection, and whether I can achieve an R0 resection with an endoscopic approach. The indications, contraindications, we'll come to that in the next presentation. But
Okay.
generally, if I'll not be able to achieve a seal after a resection, I would not do an endoscopic approach, because in that case, it's better to do a pericranial flap to achieve that seal. So a combined approach will be better.
Okay. Next
Yeah.
question is by Dr. Ratan Shetty, and he was asking, what is the sequence of your trimodality treatment in case of sinonasal neuroendocrine carcinomas?
So that's what. So neuroendocrine carcinoma, as of now, what we do is we give NACT, neoadjuvant chemotherapy, and then we would assess response, do surgery, and followed by adjuvant. The MD Anderson have published a series in JCO wherein they have given NACT, and then good responders, they've gone ahead and given chemoradiotherapy, and not they've done surgery, and then surgery they've kept it as a standby. So they found those results to be better. So it's difficult to say that is better than this, because you don't have a randomized trial to compare head on. So it can be an institutional policy. So this is what we follow in our institute. That is what MD Anderson follows. So depending on the expertise available, you could definitely consider either of them.
Okay. So, sir, good question by Dr. Vivek. In
Yeah.
case of CADISH A of a post-endoscopic resection, HP showing olfactory bulb infiltration. What would the role olfactory bulb infiltration?
So in CADISH A, that's what you need to evaluate pre-operatively itself with an MRI as to how extensively the lesion is going. So CADISH A, you expect it to be within the nasal cavity. It's not going to the paranasal sinus. And intraoperatively, you will decide as to whether you want to remove the olfactory bulb or not. If you're going to remove the olfactory bulb, it automatically goes up to CADISH C, in which case you would want to give adjuvant radiotherapy.
Oh, okay, sir. So for today, the last question is, what is the expectation and management of presence of skip metastasis in paranasal sinus tumor malignancies?
Skip metastasis meaning? I'm not able to understand this question.
I think the skip metastasis is two sinuses with in between a sinus which is not more. I think so.
So more or less. So I think I can, if I can understand it rightly, skip metastasis meaning if it is beyond one cell.
She was telling along the nerves.
So meaning to say perineural spread.
Yeah,
I think that is what she's saying. So most often perineural spread you will see in cases of adenoid cystic carcinoma. That is one case where you will most often see a perineural spread. So that is again one thing that you will assess during your preoperative imaging. And if there is a perineural spread in a squamous cell carcinoma, you wouldn't want to operate that patient. You would probably give a non-surgical treatment option for that patient. And also many of the high-grade histopathologies, you would not probably do surgery. But in adenoid cystic, you can still go ahead and do a surgery and get an R1 resection at least and give adjuvant therapy, because these patients, adenoid cystic carcinoma, they tend to do well even despite all of this compared to rest of the histopathology.
So that's it for today's session, sir.